I'm not going to push it. I'm not going to rush it because I have, as I was saying to everybody now that we're recording, uh, probably the last bit, which does go over back sexually transmitted diseases. I recorded something on that for my advanced phys class, which would be no different than what I would present to you. So I have that already on board, and I have that ready to send out as it is. So, further ado, we will do this. Let's get on with it. Female reproductive, forthcoming. So when we talk about this particular system, I do not want to spend a lot of time going over uh, the anatomical basis. No, I mean the same regulatory things, the same arc, the GnRH arc, except rather than testosterone as it is in the male, the only hormone we have estrogen and progesterone. And really, the focal point of this is to talk about the two major cycles, the ovarian cycle and the menstrual cycle, and their interdependence and their dependence on these hormones to function properly. That's really what this is all about. Same deal. Anatomically, you have the primary organs, in this case, the ovaries and everything else is an accessory. So to me, it's an anatomically simpler system than the male, comparatively speaking. The focal point is the discontinuity. That's the odd thing about this, where the male, it's a closed system because if those sperm get exposed to the bloodstream, we're going to have, or any other tissue, you're going to have an immunological attack. Different here. Eggs, female is born with maybe 450 million or so eggs divided roughly equally between the two ovaries. But when they're ovulated out, they are basically, there's an opening here. It doesn't appear to be an opening, but as the egg is extruded at ovulation, it's temporarily in the abdominal pelvic cavity, and that's where there is a small but a distinct percentage of occasional ectopic pregnancies there, even though the classic ectopics are within the tubes. So that's the first anatomical difference. So as that egg is ovulated, it's temporarily in the cavity. It's a tiny distance, but it's a distance where it's exposed. And the flip side of that is infection and disease or cancer coming out from this area, from anywhere in the female reproductive tract, has a very easy, because this is open rather than enclosed and protected, to be able to spread within the abdominal pelvic cavity. So it's a two-edged sword in that regard. So stuff going in and stuff going out, there's a space. This is anatomy. The whole thing about this, without getting too distinct about this, just to show you anatomically, and we'll skip that for the time being. Okay. All of these structures, so you have a large amount of soft tissue, which they call ligament. And really what it is certain thicknesses of soft tissue that include ligaments that support the ovary itself. So you have the ovarian ligament and this large thing we call the broad ligament. So when something gets irritated, whether it's in the uterus, whether it's in the tubes, whether it's the ovary itself, it inflames the whole area. And really, what I'm saying, the framework is something that's associated with sexually transmitted diseases called pelvic inflammatory disease. It is awful. Fortunately, in women, a lot of times sexually transmitted diseases are relatively silent, or not recognizable, or not distinct until they become a five-alarm fire. Once they get up into the tubes, at that point it starts to inflame the whole area, and typically this is ultimately it's a plumbing problem. It starts here, it causes damage, basically prevents outflow, and allows basically backing up, just like the urinary tract would be effectively a plumbing problem, or the digestive tract. Uh, Ultimately, it backflows here, and the infection goes this way. It can lead to the ovary. It can lead to inevitably. And the only way we diagnose is on a pelvic exam, and it goes from being something that's just starting to present as pain and illness and fever, and then all of a sudden on that exam, the pain is excruciating. At that point, that's full-blown PID, which is the acronym you'll all be used to hearing. And what that basically means is a very high likelihood of ectopic pregnancies. ovarian dysfunction, early hysterectomies, infertility problems, all of the above. So here you can see they give you diagrammatically, if you did not know, the egg matures and eventually is ovulated out along the exterior, we call the cortex, the outer portion. The medulla is blood vessels, nerves, lymphatics. But one egg is selected here, what they call it, from the primordial and then the primary follicle. And then it matures into what's called a tertiary follicle, which has that fluid. So another term we call it is a vesicular follicle, or it has what that fluid is called an antrum. And that exerts a push on the wall, which weakens with these hormonal controls, and out pops the egg at roughly mid-cycle. Okay, and it's associated, as you will come to see soon, with a surge of luteinizing hormone, a surge of LH called the luteal surge, and you have to know that. That's the trigger that allows this final push for this structure to weaken and the egg to be ovulated out. The enclosure, the follicle itself that surrounds that egg, what happens is the egg is ovulated out, it changes. And it changes to this yellowish body called the corpus luteum. Again, Luteum, that word implies yellowish in color, which it is. That takes over with the production of estrogen and progesterone for the next 10 days. It's exactly for 10 days. In the event of implantation, then it will continue on for roughly the first trimester until the placenta takes over producing estrogen and progesterone. If there has not been implantation in 10 days, in other words, there's no pregnancy, it will begin to die. Die may be a bad term, but it'll lose its function, it'll shrink, it'll become what we call the corpus albicans, which rather than the corpus luteum, which means yellow body, albicans means white, and it deteriorates, no longer functions. And without the production of those hormones, principally progesterone at that part of the cycle, that will be the cause of menstruation. That will be the event that triggers it. That's really a summary of what goes on here. Just looking at that one illustration that they have here for us to look. So the outer part is the cortex. That's where the gametes, the eggs are forming. Remember, all the eggs are there, and if we don't complete, it's not like when sperm are ejaculated. When sperm leave the seminiferous tubules, they're fully formed. Okay, and I beg your pardon. When they leave, once they get to the epididymis, now they're sperm. They're capable of doing what they have to do to fertilize. The egg is not. The eggs are, when you're born in the female, the eggs are arrested at what's called prophase 1. That's that early stage that I looked at. We looked at a little bit on the board the other day. Basically, were some of those genetic events that increase diversity. So it stops. There's 2 phases of meiosis. It stops in the first one. It's its earliest stage. Okay? When it's ovulated out, it has completed that first stage of meiosis, and then when it's ovulated out, it's still midway. It's in what's called metaphase 2, the second meiotic division, but in metaphase, it's not completed. It doesn't complete unless there has been fertilization. And if there's fertilization, it will complete and go to the end of its cycle. So it's a unique system, unlike the sperm and the male, which are effectively ready and mobilized to do their purpose. Again, you have to understand repro. I'm not great at it. Is to understand the goal of the exercise. If you understand it in my concept, the goal of the exercise is fertilization, then to me it becomes a little bit clearer. And as you can see, it's just fraught with things that go wrong. And that's my context for the things why it didn't work, so to speak. And I could complain about my biological children rather than my adoptive children. So I'm sure I would complain equally about both. So, and again, the tube system, not direct contact. This is the anatomy. I don't need to go over this. It's very straightforward. Where does fertilization normally occur? In the tubes, whether they're uterine tubes, whether they're fallopian tubes, whether they're oviducts, same thing. not where it opens, but about 1/3 to halfway on its way to the uterus. It's not a particularly long journey where it occurs, but that's typically where it occurs. And then once it's fertilized there, it takes about 7 days, roughly 6 or 7 days to get to the uterus. And if it's going to implant, I mean, in the absence of fertilization, obviously nothing's going to happen. And even sometimes in the presence of fertilization, it doesn't implant. That's, again, one of all those interesting things that unfortunately go on. That's the opening, the ampulla. This is where the fertilization's fancy name. And as it narrows, when things narrow, often we use the term isthmus, rather than being a portion of land with two bodies of water on either side, like the Isthmus of Panama, where the canal is. For you geography fans, don't they still teach geography in high school? No. No? See, we got to know where all the countries are. So, and all of these types of things, in ovulation, there's all sorts of, I mean, during that process of ovulation, the fimbriae, the little finger-like projections, have cilia. They create little eddies and currents to sweep the oocyte, okay, into the area in preparation. That's really it is. There's not a whole lot to say about that or anything. Ectopic means somewhere where it's not other than in the uterus. Typically, implantation is not so much in the dome, though it can be of the uterus, which is called the fundus, just like the dome of the stomach, but somewhere in the wall itself. And again, here's this all about PID, pelvic inflammatory disease. Statistically, I could repeat my micro lecture from this morning. It is alarming, the increase in these. We had a nice little drop when HIV reared its ugly head, for those who didn't have my micro lecture this morning. But now we're the better part of 35 years after let's say good 30 years after the first HIV scare. And all of a sudden, people have forgotten how destructive and life-altering these diseases are. It's hard, whatever you want to achieve, and many times they're fatal. So not a whole lot to say about this. Is the uterus. If you go back to that original, the uterus is draped over the bladder. But what happens, and that's its normal position, puts pressure on the bladder, like a pregnant woman has to, urinate a lot. Basically, when there's arousal, that uterus kind of tense upward. So it makes it very easier, let's say an easier passageway for the sperm to make that journey. There's all sorts of events. Unfortunately, we do not have the time in this course to go over all of those things. If for many of you in nursing, if you're going to go into the maternal child part of it, or you're going to get courses about that as well when you start looking at more of the physiology of the way things are. These are just anatomical terms, not a whole lot about this. Big player again, HPV. The numbers are staggering. The most, in the micro PowerPoint, the text we're using, we're talking about 80% of cervical cancers are caused by HPV. These were numbers from 8 to 10 years ago, I would dare say. Killing half. Well, the numbers are beyond measure. They are. And so there are certain strains of human papillomavirus. Again, the best precautions are whatever you're feeling. If you feel this, the other PowerPoint was saying, what this morning, everybody 9 years old, when they might start using that vaccine. It is crazy. If you didn't hear that lecture, I'll reiterate the point. The area where we're seeing the largest increase in sexually transmitted disorders, are you ready? Middle schoolers, mostly related to oral sex. Middle schoolers. To understand, and HPV is very common, particularly oral pharyngeal carcinomas. Scary. So understand this is, I'll preach a bit about it. And I say it every time I do any of these lectures. We are very provincial here. I didn't say this before. It's just not something you talk about at the dinner table. Moms and dads I don't want to hear about it. We're going to be realistic. And I am, again, I am an authority on this. My daughter only had her baby before she was 16. So I speak from the voice of experience how successful we were with practicing and avoiding, things like that. Don't laugh. You could be next. This could be your daughter. But I'm not wishing it on you. But it could be anybody's daughter to be cruel. Okay? It's not the end of the world. As I was fond of saying, she wasn't the first, and she certainly wasn't the last. Hmm. What are you guys? What are you snickering about?
I'm gonna be honest. I was trying to put your notes and check maybe a study guide, and then it started talking. You know, really.
Your notes are talking to you.
Yeah,
Is AI taking over?
maybe.
The whole premise of the book Dune, when it was written in 1958 to 1960, was the machines taking over. It was computers taking over mankind. It only took 10,000 years to get rid of them. If you haven't read the original Dune series by Frank Herbert back then, just pointing that out. Not the Timothy Chalamet movies. Everybody's so I know he's a nice looking kid and all that good stuff. Moving on. Nothing there about the pouches and stuff. There's the tent effect. Prolapse uterus happens a lot with women who have multiple pregnancies. There's a lot of weakness in the pelvic floor. They have a pelvic floor unit at McGee that's excellent. My recently deceased mother-in-law had a procedure done there. They, you know, because it's fairly common, women will start to have problems with a certain amount of urinary incontinence and frequent infections. What she did, they rebuilt her floor when she was in her 80s. My mom had that surgery done years much prior to that when she was only about 67. It's not easy, and she had done it in a really good hospital, but she still had a difficult time with it. So it's they're trying to. This is a relatively common thing. Multiple pregnancies, certain things predispose you to some of the problems. Again, this is a part of the anatomy is right here. This is just a giant smooth muscle, powerful, strong, contracting rhythmically as you might presume during childbirth. This is the big player here. Simple columnar epithelium and a very thick lamina propria. There are two layers. Remember the term for layers are strata. You have the stratum basalis, the base layer that's always there, and you have the stratum functionalis, the layer that's going to be designed to receive the egg when it's fertilized and which is shed in the event of the absence of fertilization during menstruation. That's it. Basalis always there, the base layer, the functionalis, we just keep recycling, shed it, we build all over it again every month. That's when we look at the menstrual cycle, we're going to marry the ovarian cycle, the egg development, maturation, release, etc., to the menstrual cycle and see what hormones, what events, what timings are there. So here's the number with that. The functionalis and the basalis. Response to ovarian hormones is the functionalis. It's the functional layer. Shed during menstruation. The basalis is always there. It doesn't respond to those hormones. This is a very well developed functionalis because you can see these glandular structures. You'll see the illustration that points the same way, but this is the actual micrograph of it. The ball game has to do with blood supply. We have gonadal arteries. They're about the ovaries. The uterine artery, even if it sends a tiny branch to the gonadal areas, this doesn't come directly off the abdominal aorta. It comes off the internal iliacs. If you go back and remember your anatomy from Dr. Robbins in the lab, you have the common iliac where the abdominal aorta bifurcates. You have the external iliacs, which go to the lower extremity. The internal iliacs kind of service the deeper portion of the abdominal pelvic cavity. That's where the uterus is. And so those arteries will go to the uterus. They'll arch over it. Remember, it's really like just a giant sac-like enclosure. And then they'll have vessels that'll go into it. And you'll have ones that go to the basalis that are straight and ones that spiral. The spiral are the big guys. They're the ones that take care of the functionalis. So what happens? If there isn't, by this time, the hormone that's taken over is progesterone. What do you want from me? Oh, God. Lord help me. Uh, Hold on. Why is there always drama in my life? Not mine, kid. But I digress. So at this point during the thing, there is progesterone. Okay, progesterone is the predominant. Estrogen does it in the early phases. Okay, but when we get into the phase where functionalis is developing and preparing for implantation, the progesterone effectively takes over. And as long as there's progesterone, in the absence of implantation, though, what happens is that progesterone, which is being secreted by the corpus luteum, stops. In other words, you're only going to make it for 10 days. Once that stops, those arteries, spiral arteries, spasm. When it spasms, it separates the two layers. Fluid collects between them. When you have an artery that goes into spasm, it builds up a pressure head. When the spasm, which eventually releases, that built up arterial blood pressure pushes and literally causes the layer to shed. That's what happens with menstruation. Menstruation is mostly tissue and tissue fluid and a little bit of blood. Less blood than you think. People need to understand that because of what it is. Moving on. So, thin wall, and so this is the anatomy for all of that. We don't have to go into any of that. Again, acidity is the watchword here. Yeah, there's lactobacillus. It feeds on glycogen. Glycogen, because estrogen is so abundant in the childbearing years in the female. Lactobacillus, which are bacteria and the female reproductive tract, secrete large amounts of acidity. That's the protection. Otherwise, that's mucus. You don't have to go through all that or that. I'm not focusing at all on the anatomy aspect of that per se, other than what may have been presented when I sent the review information. So I don't think there's a, and again, breast, which is part of the same issue here. Breast aspect of it is the most important part to understand is the breast is mostly fatty tissue. The glandular portion of it, which is really like an apocrine or a modified sweat gland, doesn't really function except during pregnancy/lactation. That's when it begins to develop and enlarge. The gland, the mammary gland tail sort of goes into the axilla. And that's why we're so concerned about, in the presence of breast cancer, going and at least biopsying lymph nodes under here, which are abundant in the axilla. It's one of the major areas. That's where breast cancer spreads. You have to do it. You have to presume it's going to spread because it's anatomically, it's very easy to spread there. And a lot of times we don't know about it until then. So, and those don't get it. So this is extraordinarily common. It's very tragic. Epithelial cells, very tiny ducts, and they metastasize, unfortunately, with some degree of rapidity. Okay. Lots of different risk factors that you can go through, but this is interesting. A substantial majority don't have this. Breast cancer have no known risk factors. 10% due to hereditary defects. Okay. And you can see that, and of course, these breast cancer genes are very important because of this extraordinarily high percentage of both breast and even ovarian. I remember those as well. And mammography, we're not going to go into that, or the treatments, etc., etc. So that leaves us, we can cut to the physiology here, and this is the part I'm not really about. I don't think there's anything, and I'll double check it as I review the exam to make sure. If there is, I will let you know. I will email you specifically if there's anything about the production of the oocytes and the polar bodies, or the granulosa cells. Effectively, they form this follicle. And that follicle is the enclosure that protects the egg. And that once the egg is ovulated out, whatever is part of this follicle becomes that corpus luteum. So, and there's a variety of slides that they have there. The follicle that is ready to be ovulated, effectively one of the, there's a number of primary follicles, but one is selected to proceed to ovulation. How that occurs, not clear. Why it occurs for that one follicle, it's not necessarily clear. So the so-called tertiary or vesicular or antral follicles mean they have that fluid-filled cavity that becomes really important for creating the force to facilitate ovulation. That's here. So that will push against the weakened wall, which has to do with the hormones that are involved, and out goes the ovulated egg, and then the enclosure, the remnants of the follicle, they become the corpus luteum. And then these are the meiotic events that occur during that time. As you can see, it's just basically started here. Even here, they're just competing the first portion of meiosis. It isn't until fertilization that it completes the second part of it. So years to complete, okay? Begins during the fetal period. The follicles are there, but they're arrested in prophase 1. Okay. So-called dominant follicle is the one that's going to develop. FSH is the critical piece for producing eggs that are there. We're not going to do the polar bodies or this. As you can see, enough cytoplasm to nourish the fertilized egg for that 6 to 7 day journey from fertilization. So the timing is well understood. Begins in fetal life, ends in menopause. And see, and different to the male, where spermatogenesis begins at puberty and can sit for a longer period of time. The onset of menstruation and menopause, there's some certain degrees of variation. I don't have the current numbers on it of any type like that. Not worried about the gonadotropin independent pre-antral phase, et cetera, and the zona pellucida. I mean, these are just more of the technicalities. But this is kind of what it looks like. That's that big antrum that's going to push on that weakened wall, and this is what ovulation looks like. It's there. So there's lots of different things that are part. It gets very, very detailed into all this. But really, it's the cycles to me are the crux of what we have to do. So here we are. So the ovarian cycle, the only variation in these cycles is here. So the follicular phase, the development of the follicle, and the development in the early stages of the egg, pre-ovulatory egg, is the variable. Usually it's a day or two variation statistically. Once it ovulates, the luteal phase is comparatively constant at 14 days. As you can see, there's a fair amount of inconsistency. It varies, but the luteal phase is always that 14 days. The dominant follicle. So here's what happens. FSH is the one that creates that especially sensitive to the dominant follicle. And then you're going to see that the FSH levels drop after that. And the same illustration is there. What happens when that follicle develops and we get that fluid-filled antral phase? The wall, that ballooning wall, will rupture the now weakened ovarian wall. Typically, they refer to that, they call it Mittelschmerz. It's notable. There's a lot of things. Sometimes it's not as apparent. When my first wife and I were trying to have kids, we did basal body temperatures. So she would take her temperature first thing in the morning, and before digital thermometers. So you had a special thermometer that you could read into, rather it was like 96.82 or 84. So you were looking for a spike. And that would typically be, that spike you plot those out, when you saw that spike, it would typically be for ovulation when you might consider trying. This is the whole idea: 1 to 2% release more than one secondary oocyte. Fraternal twins, identical twins result from fertilization of one oocyte that happens to separate. Okay. And again, sometimes there's unrelated levels. So sometimes it's almost a way of understanding accidental pregnancies. If you did not know it, for people who do IVF, if you have a history of multiple births in your family, it really increases the numbers significantly. Significantly. As you might have multiple births if you undergo IVF or have some type of, how should I say it? There's a variety of things trying, if not IVF, there were other things that were used to try to stimulate ovulation that my first wife went through. And so here, I'm not worried about the corpus hemorrhagicum, but the luteum, the granulosa cells and what they call the thecal cells, that secretes mostly progesterone and a fair amount of estrogen, but it's that second phase of the ovarian cycle that we see the predominance there. And again, if it's not in 10 days, the whole idea is this is going to take over for the ovary producing estrogen and progesterone, except in this, estrogen predominates pre-ovulation, progesterone post-ovulation. And at that point, after 10 days, in the absence of, what happens is once it's implanted, the uterus, okay, sends a chemical messenger to the ovary and says, we've had implantation, corpus luteum, keep busy until we build a placenta, about 3 months. That chemical is called HCG, human chorionic gonadotropin. It is very easy to detect, and that is the source of the very reliable early pregnancy test. Comes from there, and that's produced in fairly large amounts, relatively quick, very predictably. So as I think most people are familiar with how effective those are, like 99.7% accurate, some relatively high number like that. You saw that illustration before. It takes a while for it to get established, but once it does, so typically, I just can't give you a figure. It's just the whole idea is that you have to have adequate fat levels. Okay. I think that's really important. So as long as you have adequate fat levels, things are good. And we're able to go with this type of thing, stimulating FSH and LSH released by the pituitary that acts on the ovaries. So it's a big point. That's how people manipulate in sport, figure skaters, how they manipulate gymnasts because puberty is against you, body type speaking. It's a whole lot easier to do it. I've seen it in figure skating. I've seen it in gymnastics. I intentionally, not the fact we're trying to limit the onset of puberty, trying to limit the onset of proper menstruation. What word comes to mind? Evil. I happen to think it's wrong. We're good. From someone who was my daughter was a good figure skater who didn't love figure skating, we would never consider doing anything like that. We knew people who they did this to. We knew someone from this area who was extraordinarily talented, nationally talented, won national championships, and the parents very controlling, very bad, very bad. So I'm not going to go into the same arc that we had talked about previously, because it's the same one that's there. You don't need to know about that. But this is the big player. And really, and again, this is one of the areas where we see a fair amount of positive feedback. I think that's worth noting as well. Now, again, it's easier for me why I'm buzzing through it this way, even though I've talked about it, is I want to show you the cycles and compare them. So we have the ovarian cycle, say summarized here to a certain extent. And let me go forward, and I'll go back to the menstrual cycle. This is the correlation. In the uterine phase, here they're comparing what happens in the ovarian cycle, when menstruation starts, then that's the time when, at that point, where the ovarian cycle begins to take over. The ovaries then begin to produce their own estrogen and progesterone and start the development of the next egg. That's called that particular is called the follicular phase. Then there's ovulation, and because the corpus luteum takes over, it's the luteal phase. Again, this is the area of the phase that has that, let's say it's not a consistent number of days, even though they're talking about day 14 being typical. This second, the luteal phase, is the one that's very consistent. Again, and so this always starts, effectively, menstruation always starts the new cycle. It's either, so even when we're talking about the uterine phase, it starts with menstruation, typically 4 days, sometimes 5 days. So that's the first one. Let me get backwards. So that's the ovarian cycle. In the menstrual or uterine cycle, series of changes start with menstruation. Most authors say it effectively ends at day 5. Again, the egg's already developing for the next go round. At that point, that estrogen is the predominant chemical that's going to cause proliferation, okay, of starting, remember we have a stratum basalis that's there, where you're going to start to proliferate and build the new functionalis. Post-ovulation, what they call the secretory phase, now the functionalis is going to enlarge, mature, and develop glands that are going to secrete chemicals that are going to become what effectively that egg, once it's implanted, are going to use as nourishment. Remember, previously, that egg has enough to last for 6 to 7 days. It's got the implant to be able to obtain nourishment after that. So at the start, estrogen and progesterone are low. What happens because of that? The gonadotropin levels rise. Because of that, we're going to have outpouring of SSH and LH. So the FSH is going to start the new egg to begin to function, to begin to be released and matured, so to speak, selected and matured. And the LH is going to make estrogen and progesterone. Okay. All that happens as soon as that functionalis detaches. Okay. So by day 5, growing ovarian follicles are now starting to produce more estrogen. Those estrogen levels start the functionalis, thickens, enlarges, etc. Estrogen increases more receptors. Okay. The mucus facilitate. I mean, all of these are interesting changes when you get into the ins and outs, so to speak. And ovulation causes it then typically day 14. This is the consistent phase. It's all about preparation. Secretory, because that layer becomes a secretory mucosa. The glands enlarge, secretes. Now it's going to make a mucus plug. Because by this time, understand fertilization would have occurred. Now we just don't want, now the mucus plug will form, assuming that occurs, to prevent the loss of the egg. And so if it doesn't occur, the corpus luteum degenerates, the levels fall, the spiral arteries kink, everything, as you can read through it. Once they constrict again and then relax, and because of that, the pressure head, that flow of blood, takes the layers which have been weakened, the connection between the basalis and the functionalis, and it's shed. And we just start the whole thing over again. So these are the summary points. Thankfully, we're near the end of my discussion. Okay. We call that the luteal surge. That's the trigger point. You can see FSH, pretty constant. There's a little surge, a little enlargement, but compared to luteinizing hormone, immense. Immense. So that's the luteal surge that's noted and specifically responsible for ovulation. Okay. What do we see happening here? And you saw the slide before. We have, again, once that occurs, we're restarting the cycle. Now there's an absence because the corpus, that's no longer making anything. Effectively, that's the signal for FSH and LH to get busy. When that, as that deteriorates and ends, they start to produce by this time a sufficient amount of estrogen and progesterone to start the next follicle to be selected, enlarged, and eventually another luteal surge, and We go through that cycle again. We have the follicular phase and then the luteal phase. As you can see, once after ovulation, now we're past the proliferative phase, and as you can see, when progesterone takes over, that's what really makes that glandular aspect. That's the secretory phase. So here in that proliferative phase, the estrogens play a pivotal role, peaking just before ovulation. After that, they go back down. They're still at a high level, but look at the increase in progesterone. That's the pivotal piece. They're both important, but that's the pivotal piece for that phase. And you can see what's going on here with regard to the preparation of the bed that's there. And to me, if you look at this slide, it tells you everything you really have to know about the physiology. It's the marriage of the ovarian phase and the uterine phase and all the events that occur, whether where the luteal surge is, what's happening at ovulation, what's happening before, what's after, the names of the phases. They're all important things to know. And all of these types of things, menstruation, again, this is that body fat. For normal reproductive health, women need, on average, between 5 and 15% body fat. Much more so than the male. Much more so. Because the reproductive health is so reliant on these. And the trouble is, without this, okay, if you don't have regular estrogen and progesterone, particularly estrogen, now you're paving the way for a lot of metabolic problems, not the least of which is osteoporosis. All of these are part of it. These are. So, female athletes, little or no body fat, that plays a role. That lack of leptin shuts down. So if it's done, you can see why people will do this intentionally. So it can reverse if a woman increases her body fat. Young, healthy women can still see dramatic bone loss, usually seen in old age, because of this. Okay. So what happens? Estrogens, they promote obviously oogenesis and follicular growth, anabolic effect, growth spurts in puberty. We knew about secondary sex characteristics, etc. But what does it do? It maintains right levels. Okay, we want high HDLs. We want low cholesterol. This is the so-called good cholesterol. All it means, these high density lipoproteins are associated with exercise and activity. They are the ones having high level of those consistently fights against cardiovascular disease. We need calcium. And so the estrogen, that's why the absence of estrogen in menopause, why do we see osteoporosis? Why do we see an increased risk of cardiovascular disease? All of these are part of it. Okay. Why do we see, basically hot flashes, additional problems that are associated with it? It's really very, very difficult. Progesterone works with it to establish the cycle. The mucus, whether it's going to be loosened or as a block, effects of placental progesterone during pregnancy, inhibit uterine motility, prepare the breast for lactation. It's summarized very, very nicely here. Nothing major here. You can read through this. Very similar to the male. Parasympathetic predominates in the arousal phase, and sympathetic is what creates climax or the orgasm phase. There's there. And that's it. I'll send you my little synopsis separately on that. And we're good. Oop, didn't mean to do that. Thank you. We'll see you. Like I said, I'm here, and if not, we'll see you.